Hi, I'm Alicia.
And I'm Robin, and you're listening to Bowel Moments,
the podcast sharing real talk about the realities of IBD. Served on the rocks. This week, we talked to Dr. Lukasz Kwapisz, assistant professor and IBD specialist at the Baylor College of Medicine in Houston, Texas. We discuss his passion for inflammatory bowel disease, his special interest in J-pouch disorders, his clinical trials experience versus his real-life experience as a provider, the importance of early intervention for people with inflammatory bowel disease, and our mutual love of tequila. Cheers.
Hi, it's Robin, and you are listening to another episode of Bowel Moments.
Hey guys, this is Alicia, your co-host, and I am very excited to welcome our guest. We are joined by Dr. Lukasz Kwapisz, and he is an assistant professor and an IBD specialist at Baylor College of Medicine Medical Center in Houston, Texas. So welcome. We're going to just call you Lukasz because Kwapisz does take a little bit more dexterity than I will probably have after finishing my drink. So Lukasz, please tell us a little bit about yourself and how did you join our IBD community?
Well, I should say Kwapisz is actually a beautiful name. It rolls off the tongue. And
it is a beautiful name.
It is a beautiful name, and it's Polish. So a lot of people are wondering, wonder where's that name from? And so I tell them, typically, I say it's pronounced like Kwapisz, which is the Italian word for do you understand, but I say Kwapisz. And so with my patients, I often either get called Dr. K or Dr. Kwapisz once they get used to saying it. I warn them that if they say it too many times, I'm like a genie. I show up, either in their house or in their dreams, whatever it is.
How delightful.
But sure, Lukasz is fine.
Okay.
Yes, I know. Very important backstory. Yes. Okay. So what was the question? How did I join the IBD community?
Yes.
Okay. Yes. I will say this. I mean, little background. First we do internal medicine. That's our first residency. And then when I was an internal medicine resident, I was, considering what subspecialty, and it happened to be almost serendipity. My first rotation as an internal medicine, resident, I was on gastroenterology, and I had these amazing mentors. They were these, I would call them young guys who were very much into sports, and they were so cool. And I was like, oh my gosh, I want to be just like these guys. And they happened to also be IBD specialists. And at that very same moment, almost coinciding, one of my closest friends was suffering from Crohn's disease and was undergoing surgeries and was very, very sick. And I knew very little about Crohn's disease at that moment. And I kind of felt bad because I was like, I really wish I could help her going through all that she's going through. And I offer some counsel or something to that effect. But it was a perfect storm literally in that moment for me to be like, okay, I really am fascinated by all of this, and it all just kind of came together perfectly. And from there, I was lucky enough to get into the GI fellowship. And once I was in GI fellowship, I was crazy enough to be like, well, I want to subspecialize even more. And I was, again, very fortunate to be able to go to the Mayo Clinic and do an advanced fellowship in inflammatory bowel disease. And there I got a chance to learn from the world's brightest minds when it comes to inflammatory bowel disease. I mean, they're the world experts, and they were my mentors. And I was like a sponge. I just tried to absorb everything that they did. I thought I was a pretty good doctor going into Mayo Clinic. And then I learned from these incredible physicians how to, not just the knowledge, but how to conduct yourself, the professionalism, the attitude, the research. I mean, it was so eye-opening. And every single day, I just, I was almost mesmerized by the way they taught inflammatory bowel disease, the way they treated inflammatory bowel disease, their connection to their patients. And yeah, I was very fortunate after that, after finishing that IBD fellowship, that I wanted a job in an academic center where I could really focus and really hone in those skills and help a community that has a lot of inflammatory bowel disease. And so I moved to Houston, Texas.
Yeah, that's certainly, the Mayo Clinic is kind of one of those gold standard places. So what an awesome place to learn. Plus, beautiful Minnesota, where I am now, is, you can't beat it for gorgeous weather. We forgot to ask you, and I apologize. We usually start people asking, what are you drinking? And you told me you wouldn't tell us. So now I'm very curious.
Well, I wasn't going to drink because, it's 7 p.m. on a Tuesday, but you guys insisted. Yeah, you inspired me and insisted. And I've had a really, really, really long day, and I just got home. So I'm drinking tequila since that's my drink of choice. And this is Clase Azul. So it's the white and blue bottle that has a little ring on it. So if you ever, see people smacking a bottle and it makes a ring noise. That's the Classy Azul bottle. So that's what I'm having. Cheers.
Lovely. I am also drinking tequila. Mine is Terramana, which is Dwayne The Rock Johnson's tequila. Can't say enough good things about it. It is actually very delicious. But in our previous episode, our guest Stacy was talking about how much she loves tequila and Topo Chico. And so ever since she said that, I'm like, ooh, that sounds really good. So I'm drinking tequila and Topo Chico. So I highly recommend.
If you happen to know this, so Texas, I think Texas is the one, since I'm in Texas and I think you used to be in Texas. They came up with a drink called the ranch water.
Yes.
The ranch water is literally tequila with soda, or a Topo Chico specifically, and then they add in a little bit of lime juice. And so that is called the ranch water. So
is that what you're drinking, Alicia? Ranch water?
Yes, I am drinking a ranch water. Yes, I did substitute though, because I did the Topo Chico with the twist of lime in it, because I tried it with just the regular Topo Chico and it was still a little tequila-y for me. So that was with a different brand of tequila, though. I probably would be better with Terramana, not sponsored by, but just saying.
Hey, The Rock, if you'd like to sponsor us, just saying.
We would not turn down sponsorship by Terramana delicious tequila.
That's right.
Okay, sorry. We took it, and Robin is being born and drinking water, so we're not even going to.
I'm being boring.
Boo.
That's okay. You can ask. I mean, water is a necessary for life. And I do have a pouch. I was feeling a little dehydrated today, so I figured I should probably stick with water and be like a responsible adult, which is also boring.
Well, but speaking of pouch, as I was looking at your profile to get prepared for this interview, you note that pouch disorders is something that you have a particular interest in. And since we have covered a lot about J pouches in some of our previous episodes, I'm curious, talk to us a little bit about pouch disorders. What are they? Number one, what can happen? And why pouch disorders? That's such a unique area, I feel like.
It is a unique area. And again, I think most of it actually stems from my experience at the Mayo Clinic. I had a colleague of mine who is a GI fellow there. His name is Kevin Quinn. He's very brilliant and wonderful. And he had a very keen interest in pouch disorders, along with one of my mentors there, Dr. Laura Raffles. And when I was doing my GI fellowship, I really didn't see that many patients with pouches. I really, to be fair, even when I got to Mayo, I was like, oh my gosh, like, what happens when I run into someone with a pouch? Because I don't fully understand it or know it all, or, would have a good approach. And of course, the folks that come to the Mayo Clinic have very refractory disease, and pouch disorders were very, very common. And so while I was there, I mean, when you don't know something, you start reading about it more and more. And then when you start seeing it more and more, it kind of solidifies in your head. And I think a lot of gastroenterologists don't have a lot of pouch experience and consequently don't feel that comfortable. And I belonged in that boat until I thought. So, I mean, a brief rundown of pouches. Most of the time, someone has a pouch because of ulcerative colitis, and they get a colectomy in either 2 or 3 stages, and depends if they're on immunosuppressants or the surgeons that they're working with. In rare cases, you might see someone with Crohn's disease who gets a pouch, but that would be tremendously unusual. But once you do get a pouch, I mean, fundamentally, we tell our patients that you're not out of the woods, you're not out of the water in terms of symptoms. We expect patients to have 6 to 8 bowel movements after getting a pouch. So, I mean, one of the reasons a lot of patients do want a colectomy and then get a pouch is they're sick of having a ton of bowel movements. They're sick of going to the bathroom 10, 12 times. And we always tell our patients that, look, the average is still 6 to 8 bowel movements after you get a pouch. And one of them could be a nocturnal bowel movement as well, which is very tedious to wake up in the middle of the night and use the bathroom. So from that vantage point, I mean, that's what can happen once you have a pouch. But there's also a lot of complications that happen, both from an inflammation perspective and an infectious perspective. And sometimes folks end up developing Crohn's disease of the pouch. We thought they had ulcerative colitis, but next thing you know, we do a scope and we find deep ulcers, and it's really Crohn's disease. We certainly see infections from C. diff, which is very, very common. We see ischemia, or the lack of blood flow to the area, which can be very problematic. We see, certain medications can make things worse, like NSAIDs. So we always think about that. And then, of course, a lot of these infections, which end up producing some form of either recurrent pouchitis is what we call it. And that could be quite challenging for a lot of patients. It could be very frustrating because they're constantly being cycled on antibiotics. And that can be problematic to a lot of people. And then the last thing we always take into account is that there's mechanical complications. So the idea that there could be a surgical problem, there could be a leak, There could be an abscess, there could be fistulas, strictures, narrowings, all these things that can form. And then the pouch itself might not be able to empty very well. So there's so many, I mean, I feel like this could be a whole podcast, and I don't mean to be too in depth about it, but there's so many things that could go wrong with the pouch. And that can trigger, again, a lot of symptoms and problems and issues. And patients are never completely out of the woods, even when they do get a pouch.
But we don't want to scare anyone.
Yeah. Good luck, everyone.
As I sit here terrified with my brand new pouch, but that's nothing. It's fine. I actually listened to two surgeons this weekend talk about pouches, and afterwards I said, thank you so much for your talk. It was so informative and also terrifying. So I feel like we're just continuing that conversation. I do want to ask one follow-up question. You said something at the beginning, and I think a lot of patients who have mild to moderate don't know what refractory disease is. And if you could explain that a little bit as for general knowledge for the 10 people who listen to this podcast.
I think we're up to 15.
Oh, 15.
But are you...
Just define what refractory means.
Like, what do you mean when you say refractory disease? Because a lot of doctors talk about that, but it's not just it's not just a general term that everybody with Crohn's or UC has refractory disease. And
sure. I mean, in layman's terms, refractory just means that something comes back. So the disease comes back. And again, when we look at the two disease entities, ulcerative colitis and Crohn's disease, there are certain treatments that we start patients on based off the severity of inflammation or presentation that patients have. And in ulcerative colitis, that's often a mesalamine complex, which Lialda is probably the most common one, but those are oral pills if it's a mild case. Sometimes we do rectal enemas or rectal suppositories. In Crohn's disease, we don't have those pills, mesalamine, those aren't really approved. We often start off with some form of a steroid in the mild case, and then can progress to a biologic agent. And of course, we could do the same thing in ulcerative colitis. We can progress to a biologic if the disease is not well controlled with the mesalamine complex. So refractory essentially means we start someone on something, and either A, it has never gotten better, or B, it has gotten better, but now it's come back. And so it's almost in some ways, there's active inflammation despite treatment, and it's refractory to the treatment. It's not working. Whatever we have you on, it's not working. And if that's the case, and there are next steps that we need to take in the form of either medical treatment or surgical treatments. I mean, there's many different options that we have to undertake.
I have a curiosity question because, again, I'm throwing you a curveball in this one because I just thought of it. I am curious what it's like to scope a pouch. Is it vastly different than a typical colonoscopy?
Is it?
Well, that's an excellent question because I almost wish that there were GI fellows listening to this, because it is a lot different. And there are some things that our fellows and all gastroenterologists should be outlining when they do scope a pouch. Number one, it's much shorter. I mean, there's not that much distance. So you start off and you go through the rectum. There's often a very short area of the cuff, of the rectal cuff. So there's usually a few centimeters there that you get to go into. And then when you look, there is the pouch itself. It has an afferent limb and it has an efferent limb. So I mean, I don't mean to get into too technical terms, but we look down both limbs of the pouch to look at in appropriate detail. We look at the inlet. So, what does it look like when you go into the pouch from the small intestine? And we definitely take a look at the whole thing. And there are various findings that are suspicious for different disease processes. So it's really important that once we do our scope, we properly outline what we find. We describe, as I mentioned, all of those landmarks, which are important, from the afferent limb, the inlet, the tip of the J pouch, the efferent limb, you got the outlet, the rectal cuff. You have all these little things that you have to look at very carefully and describe. And for inflammatory bowel disease specialists like myself, these are very critical things to mention, and especially if there is ulcers, where they are, and so on and so forth. So these are very important things.
Yeah, it seems like it would be a little bit fun to scope a J pouch just because it goes a little faster, but it's unique.
It's definitely unique. I mean, there's, again, not to belabor the point, but there is something called an owl's eye. So if you think of, the way an owl's eye looks, that's how the pouch body looks. We can look down the very middle and you see literally two openings, and it looks kind of like an owl's eye. So that's the appearance that we describe in the body of the pouch. And yeah, I mean, come by sometime. I can show you some pictures. We'll have a good time. We'll drink tequila and we'll look at pictures of pouches together.
Sure, we'll take you up on that one. Maybe we can do some screenshots for our Instagram for that one too. Could be fascinating for our folks as well. So in our last couple of episodes with some of our guests, or patient guests specifically, they talk a lot about testing. And so I'm curious if you can help us out a little bit, because I know not everybody is completely familiar with testing. Like one of the things that came up recently I know Robin and somebody else I was chatting with was fecal calprotectin. And so when you have a patient that comes in, maybe especially a patient that's new to you, what tests are you running and why are you running them? And what do they give you? Like, what does fecal calprotectin mean? Like, what are you looking for?
No, and that's a great question, Alicia. So when a patient comes in and they have either ulcerative colitis or Crohn's disease, you always want to kind of have an assessment of the lay of the land. Like you want to be able to know the degree of inflammation, and you want to be able to categorize someone as mild, moderate, or severe. It paints a picture for you, and then obviously the primary care doctor and maybe other physicians that are involved in the care. And kind of standard protocol when we see a patient for the first time with inflammatory bowel disease is we'll do some blood tests. And I often will counsel my patients that on my blood test, we check the routine panel. So we want to make sure the hemoglobin, which is the oxygen carrying capacity, is okay, that no one's anemic. So we do that whole CBC. But then I often will tell my patients that we need to check your inflammatory markers. And in the blood, your options are C-reactive protein or an ESR, which is an erythrocyte sedimentation rate. I just pretty much stick to the CRP, which is the C-reactive protein. So that in the blood gives me a rough marker of inflammation. Now, not every patient with inflammatory bowel disease will produce a CRP or C-reactive protein. So that's not always that specific. In fact, I was always taught that it only is accurate in about 50% of the cases. So if someone has a normal CRP, that doesn't mean that they can't have active inflammation. Their body or their liver in this case might not be producing CRP, so it becomes less reliable. And where that's important, because that's part of the blood test, and that looks at inflammation in the blood. But in the stool, we've come up with an entity called fecal calprotectin, which is a stool test, which the easy understanding of this is that it shows the inflammation in the stool. And in some cases, or not in some cases, in all cases, we think this is much more specific because this is a marker or protein of inflammation specifically in your stool. So if you have lots of inflammation in your intestine, you would expect the stool marker of inflammation to be much, much, much higher. And in that case, that's what fecal calprotectin is. So I will always check in the blood. I will check the C-reactive protein up front. I'll check that CBC. I'll check some nutritional markers. To me, vitamin D is very important, vitamin B12, iron panels, those things are always very important to me. And then in the stool, if a patient comes in and they're having lots of diarrhea, kind of my upfront two stool tests will be a fecal calprotectin, which is a stool test, as I mentioned, looking for inflammation. And I always check a stool for C. difficile, which is I always tell patients, a bacterial super infection, because you'd hate to miss out on a simple infection. It's not that simple, but it's a simpler treatment. You give antibiotics for 10 days and you can improve the symptoms. So blood tests, stool tests, those are kind of upfront. And then depending on the disease course, depending, is it Crohn's, is it ulcerative colitis, depending when the last imaging was, when the last colonoscopy was, that will kind of push me into one direction, whether or not I need to restage the disease or relook in detail to see how much inflammation, where's the inflammation, what treatment's working, not working, what do I need to change or figure out and optimize the care for the patient.
Got it. Okay. So you do all of that. You have a new patient. As you're trying to look at the constellation of symptoms the patient has, and now all of these tests that you've just run for them, one of the conversations we got into with Dr. Ashish Patel, was about personalized medicine and how we're getting a lot closer to personalized medicine. And one of your things that you like to research is combination therapy. So And as you sort of, again, look at the constellation of symptoms, you look at these tests and you take this patient as a whole, how do you then decide on what's the best course of action? And then after that, why are you looking at combination therapy and when would you use that? But hold on that one, because I think we probably have to define combination therapy. So start with like, okay, what are you looking at and how do you make the determination what's going to be the best option?
Great question. I often, when I meet a patient for the first time, I begin by explaining a little bit, and I'm sorry, I'm going to go into a little bit of detail here, but it's hopefully a worthwhile listen. I always go into with patients what inflammatory bowel disease is, or what ulcerative colitis is, or what Crohn's disease is, because oftentimes patients come in and they don't always understand what it is, right? Like, I mean, they were told, hey, you have ulcerative colitis, or hey, you have Crohn's disease, and their family members are asking them like, what the heck is Crohn's disease? What the heck is ulcerative colitis? Like, what's going on? And so I begin by telling all my patients that it's an autoimmune disease. Well, good luck. You tell someone it's an autoimmune disease, they don't really understand what that means either. I mean, it's a nice flowery term, but what does that really mean? So I start saying, well, it's an autoimmune disease. So you'll start off by telling your family you have an autoimmune disease. And within that, that means your body's own immune system is attacking your GI tract, is attacking your intestine. In the case of ulcerative colitis, it's attacking your large intestine. In the case of Crohn's disease, it could be anywhere in the GI tract. But the point is the immune system is overactive, is revved up, and it's sending inflammation to the intestines, to the GI tract. And the next logical question is, well, why the heck is this happening? And the truth is, we don't know. And we theorize that there's a genetic component, that patients inherited something from their family down the pike. And we also think that there's an environmental component. And again, we can argue all day and night, what is that environmental component? Is it something in our diet? Is it processed foods? Is it dairy? I mean, gosh, who knows? Is it pollution levels? Is it exposure to antibiotics as a kid? I mean, we can hum and haw about this a day and night, but we think that there's the genetic component with the environmental component. And together, the combination of those things have set off or revved up the immune system so severely that it's sending all this inflammation. Well, that's an important concept to understand, because the next step is, well, how do we control that immune system or that inflammation from getting there and from causing symptoms? Because you could develop diarrhea, blood, pain, needing surgery like a pouch or a resection, or having fistulas, or being in the hospital, losing weight. All of these complications can happen, and that is incredibly frustrating for a lot of our patients. And this is the part that's not so inspiring, which is what I say next, is we have certain treatments designed to help control your inflammation. But the truth of the matter is, we probably have no idea what the heck we're treating, because our biologics, which is our best medication, let's just say the best case scenario is they work 60% of the time. And realistically, that number is probably closer to 40%, but we say 60% at best. So imagine in the era of COVID, when we talk about vaccinations, and we told people, or we would tell people, hey, the best vaccine we have only works 60% of the time. I got news for you. Nobody would take the vaccine at that point. Like no one around the world. I mean, we need to hear 94, 95%. And still people aren't really like, wow, I don't know if I need it, or I don't know if it works that well. So 60% is the best case for our IBD biologic treatments, more likely 40%. Not inspiring, not great. And then truthfully, like, how do we know which biologic applies to which patient? Like, how do I know that, Stelara or ustekinumab or Remicade or Humira or all these, Entyvio, how do we know any of them are going to work, and for who? And it becomes a little bit of a trial and error. It becomes a little bit of an anecdotal experience. There is some guidelines, but I tell all my patients that inflammatory bowel disease treatment is a lot of art, and there is science behind it. Don't get me wrong, but it is art and science. And that's what particularly attracted me to the field, is that you had to think about things. And the other thing that I just like to emphasize, which certainly fascinates me, and I just want to just throw this out there, is that in our clinical trials, when we compare one of these biologic treatments, we often compare it to a placebo. Now, how in the world does someone have moderate or severe inflammation, and we give them a placebo, and the placebo maybe cures them 20 or 25% of the time? That blows my mind. We're talking about severe inflammation causing ulcers, pain, all the things, and yet you give someone a placebo and it works 20 to 25% of the time in some cases, not all cases. And now the criteria are more stringent, so that placebo rate's going to go down. But that's mind-blowing. How is nothing, a sugar medication, working? So then there must be a power of the mind effect also that helps. So I tell my patients that we will treat this together, that my patient's going to drive the bus or fly the plane. I'm the co-pilot. I will be helping the family members also in the car or on the plane, and together we'll come up with a decision. But I want my patient to ultimately decide, and I will support them, whichever biologic they pick. So again, just to kind of go over that understanding, it's important to go through that process and I believe educate and empower ultimately the patient and be their advocate, because I want them to decide. So then now we got to pick which biologic, and we talk about, do you want an injection? Do you want an infusion? There's now all these new medications that are coming up that are oral small molecules. Where do we fit them in? And in the worst case scenario, which is very rare, we sometimes combine some of these biologic or small molecule treatments where we'll do an injection and an infusion or add in the pills to try to somehow curtail and stop the need for surgery. That's the real benefit. When patients are like, please, 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 I just can't handle surgery. I don't want surgery. Give me anything you could come up with. That's when sometimes we'll combine some of these higher end treatments, but that is very, very rare. It's very difficult to get insurance approval, which is also a big barrier, but that's probably a topic for another question. But the point is, this is quite complex and quite nuanced, and there are a lot of factors that we have to take into account when it comes to making decisions.
Before you continue, I want to say two things. One, thanks a lot, Grandma, for the genetics. And two, thanks a lot. I don't want to take us off topic or go down a rabbit hole, but just when you were talking about the symptoms and the autoimmune disease and the combination therapy, what do you do when you have patients who have more than one autoimmune condition? Like the main thing is the Crohn's. Like, I feel like my GI is my BFF for life, and she knows that. Like, she's my partner, just like you said. As a patient, thank you for saying what you did. Like, you really are a partner to them for as long as forever. I mean, there's no cure. So, but then whenever I started to experience, extraintestinal symptoms like joint pain, like this is the focus of our conversation now. Like, I got the surgery, I have the pouch, like all of these things, but then I'm still having joint pain, and that's kind of increasing. So when you have a patient that is showing symptoms of other outside conditions, extra intestinal manifestations, how does that change your conversation?
So, I mean, when it comes to biologics, and now we're talking about these heavy duty medications, when we've gone past the oral mesalamine pills or the rectal mesalamine, or some folks need prednisone and steroids over and over and over, we often progress to biologics. And a very hot topic amongst all of us IBDologists, or the doctors who focus on IBD, is how do you position some of these biologics, for who gets this medication, who gets that medication. And that's a great topic. And I will tell you, when it comes to extraintestinal manifestations, so for people listening, extraintestinal implies that something outside of the intestines is also affected. And with inflammatory bowel disease, with your Crohn's and ulcerative colitis, you can have other autoimmune diseases, correctly, as you pointed out. If it's in the joints, could you have rheumatoid arthritis as a separate condition? Or is your arthritis a sequela of the inflammation in your intestines? So this is one of these things we often can debate, and having the help of a rheumatologist does often work very, very well. We tend to tell our patients that if we treat your inflammation in your intestine, then the inflammation in other areas of the body potentially will get better also, like your joints or your eyes or sometimes your skin. But the simple answer is, if you were to have strictly joint pain and maybe you have rheumatoid arthritis, let's just say that, an autoimmune disease of the joint, then we often will treat you with a TNF agent, which is either Remicade or Humira, and I'm using the trade names here. Sometimes you'll hear Cimzia, you'll hear Simponi. Those are our TNF agents, those that block TNF, but Remicade and Humira by far are the most common or most popular. So those are the ones that you'll hear of. Mm-hmm. So if someone has joint pain, we often think, okay, this is a good person to consider one of these TNF agents. Now, that's not always the case, because sometimes we can get away with adding in methotrexate, and now you're kind of covering both bases. But if rheumatoid arthritis, we often think, or extraintestinal manifestations, we often think of the TNF agent. If someone were to have psoriasis, for example, which is a scaly rash that some patients will get on their elbows, well, Stelara seems to work very, very well for that. And so we like Stelara in that situation. So there are all these nuances and subtleties. And that's why I encourage all patients who have inflammatory bowel disease to be seen at an academic institution where they see someone who specializes in inflammatory bowel disease, because they'll understand some of the subtleties and again, nuance of these difficult situations where it'll point you in one direction versus another. But that as I mentioned, I mean, some of this is we need the insurance to approve of certain biologic agents, but some of this is the experience of the IBD doctor to be like, okay, in this situation, this is what anecdotally, not just the science or the clinical trial data, but this is where I see 70% perhaps success in my practice, or 80%, and they'll know how to kind of shuttle some of the patients into those categories based off those other extra intestinal manifestations, as you said.
Yes, we have suggested several times on several of our episodes to seek the second opinion or work with your community GI and an IBD specialist, so that you want to see somebody who sees a lot of IBD. If you have a complicated case like me, you have a complicated case like me, you want to see somebody who sees a lot of IBD so that you're not the only one that's going through what you're going through and they don't know the art and science of treating that.
We've also ranted against insurance a couple of times, so that's not new either.
Yes.
Yeah, no, and I don't mean to, undermine or understate the importance of the community gastroenterologists. I mean, they're fantastic in what they do, and they're balancing a lot of things. And it just so happens that some of us, I mean, this is all I do, right? This is
right,
imagine
exactly.
I spent an extra year and a half, literally 18 months, where I was just focused. I mean, not just, but predominantly focused on just Crohn's and ulcerative colitis patients. Like, that was my life. Like, literally day and night, that's all I thought about, and that's all I saw, and that's all I wanted to treat, and that's all I was researching. I mean, and then naturally now in my practice, that's majority of my practice is Crohn's and ulcerative colitis patients. So it's something that I just feel much more comfortable in discussing and sharing. And again, the community gastroenterologist is very, very important, but they often, I think, realize that they'd like help from an inflammatory bowel disease specialist, so that perhaps they know, like, in these situations, okay, this is what would work well.
Yes.
Right,
exactly.
right. And in the case of Robin's doctor, like, her IBD-ologist said, if you want to continue working with your gastroenterologist, I'll work with that person to make sure that we sort of follow up care with you over there. But Robin just can't stop being complicated. So
no, my body did not read the textbooks. Like one of our last physician guests said, my body did not read the textbooks and is going rogue and doing whatever it wants. So yes.
Yeah. So question for you, though, on the research side of things, it seems as though, and correct me if I get this wrong, because it's likely, that a lot of the newer treatments seem to be getting even more sort of gut directed or gut specific, like they're only interacting with the inflammation in the GI system. And maybe it's not as much something that works on systemic inflammation. So if that's the case, if I've got this right, and you can tell me if I didn't, so for the people who have extraintestinal manifestations that are specifically related to their IBD, would treating obviously the inflammation in the gut then mean that these other symptoms get better as well? Or would you need to layer something on top of that?
To your point, it's exactly that. If we think the inflammation in the joints is related to the gut. So again, I think we need to just underline this again. So imagine now your immune system is revved up. It's sending all this inflammation to the gut. Well, what could happen, or what we theorize is happening, is that there's a spillover effect. So there's so much inflammation going to the gut that it's spilling out to other areas of the body, like the joints. So now you have inflammation in the joints. And we think, hey, if we get a hold of the inflammation in the gut, the joint pain will get better. We often think that. Okay, that's not always the case, but we certainly think that, especially in the cases when there's large joints or one joint, like the right knee is involved or the hip, we'll think that, that might really, really improve their joint pain. Now, we see it sometimes. It's not directly related, but if people have small joint disease on both sides, like imagine their hands, like within the fingers or the wrist, if all those joints are affected, we don't see it as much that if you control the inflammation in the gut, that it'll also help those joints, but it is something to consider. Now, to your point about gut-specific agents. So we talk about how the immune system is sending inflammation to the gut. Imagine how much easier it is selling a drug or selling or marketing or whatever you want to say to a patient if I tell you, look, not only are we trying to control the inflammation, but we're only going to block it to your intestine. We're not going to suppress the immune system to other areas of the body. We're not going to reduce your risk of getting an infection in the lungs or in the brain or so on and so forth. So if you sell that to someone, or it's a very neat marketing slogan as well as an easy sell to a patient. Sure, just give me the drug that only decreases the inflammation to my gut. And I want that one. I don't want something that suppresses my entire immune system everywhere else in my body. And so naturally, we in GI in our trials, we're trying to come up with a drug that does that. I told you 40 to 60% of the time, whatever we give at best that's what works. We're really using a sledgehammer. You mentioned personalized medicine. We're still using a sledgehammer to try to treat this inflammation. Like we have no idea. I mean, you could argue we're trying to do personalized medicine. I agree we're trying to, but I mean, we have no idea what's causing it. We have no idea which pathway we're supposed to block. We have no idea what in Robin's case is different than someone else's case in terms of inflammation. We could argue it's this interleukin or this cytokine or this inhibitor or this, whatever. No one knows. And so we're sledgehammering at the moment. We really are. And so I don't want to sound brute, but we don't know. I mean, I'd love to give you a better, more scientific and sexy description of how we're treating this, but we're not. I mean, we're trying our best, but we don't know the mechanism of action. That is critical for us to come up with. And so we're theorizing on all these different things, come up with a gut-specific agent. I mean, for all intents and purposes, this might be a weird virus or bacteria that we've yet to uncover. I sometimes tell folks, for the longest time, everyone here has heard of hepatitis C. And we didn't even know what hepatitis C was for many, many years. We called it non-hepatitis A, non-hepatitis B. That's how primitive our understanding was. We had no idea what it was. We just said non-hep A, non-hep B. Turns out we found out it's a virus that's hepatitis C. Now we came up with a pill within 8 weeks or 12 weeks, 8 to 12 weeks, one pill once a day, cures hepatitis C, gone 99% of the time. Because we actually found out the cause, we found out the mechanism, what to block, what to do, boom, done, great. Maybe one day we'll get that way with Crohn's and ulcerative colitis. I suspect it's much more complicated. It's not that simple, but we're not personalized at the moment. I'd love to say we are because that makes it sound better, but we're not because we don't know. We try to optimize care in every patient, but we don't know. Maybe in our lifetime, and I actually do believe this is the case, maybe in the next 10 years, we come up with some artificial intelligence where we're able to spit every patient's data into a computer, everything, every little part, where their disease is, when it started, how we uncovered it, which medications have failed, and we'll spit in some beautiful algorithm. And then this computer comes out with, okay, this medication is going to work the best in this situation. But we're not there yet. That might be the idea of personalized medicine down the road, but that part we don't know yet. So yes, in a perfect world, we're able to identify the specific cause, target that cause. If it's a gut cause, it's a gut-specific inflammatory mediator that we're able to block or signal that we're able to block. But the truth is all of this is a little bit, not inspiring to say, a little bit of hocus pocus, because we don't know what we're blocking. I mean, we're trying, we're desperately trying, but we really, at the moment, still are lacking the true knowledge of exactly what it is. And that's the next step, honestly. That's the next step in our treatment regimen.
Your brutal honesty is refreshing.
I was like, and this is why we drink, man. Wow.
This is why we drink during the podcast. But I mean, you're like the sledgehammer yes, that's about as precise as it gets. So you've mentioned the 40 to 60% a couple of times. And again, like Alicia, I am not a medical professional, so correct me if I'm wrong. Once the first medication fails, then the chances of the next one working decrease. The percentages decrease and decrease and decrease, in which people end up having surgery. And you did disparage surgery in an underhanded way earlier. Even though you have a special interest in pouches, but I'm a big fan of not saving surgery to the last resort. I don't even know where I was going with this now. The sledgehammer and the brutal honesty just threw me off.
Gonna get on your case.
I'm not drinking, so my brain is just all over the place right now. What about surgery as a treatment? That's where I was going with all of that, and the drugs and the percentage of time of it working going down. That's where I was going. What about surgery as an actual treatment?
Okay, so if I disparage surgery, I apologize because I actually did not mean to. So if it came across that way, I absolutely do not. I think surgery is a very viable treatment method and something that needs to be discussed right up front. And in fact, every patient with moderate to severe inflammation, I send to our colorectal surgery colleagues, to my colorectal surgery colleagues. So absolutely surgery as a treatment is an important modality, not to be disparaged. Absolutely not. And in fact, in some cases, it's the only thing that will work. And our colorectal surgeons, colorectal surgeons, most of the time, please send them to an academic institution, send your patients, because this is what they do. This is what they specialize in. But surgery is an absolute viable modality that I upfront will always present to a patient. So it's easier because most patients, upfront will tell you they want treatment. Please, 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 doctor, I don't want surgery. I don't want surgery. I don't want to go through it. There's a fear like, oh my gosh, I might have to live with a bag, or oh my gosh, you're going to cut something out of me and I don't want to live without that. And that's frustrating and scary and nerve-wracking to a lot of patients. But in some situations, the inflammation is so severe. The immune system, again, we're going back to understanding the basic fundamentals. The immune system is so active that no matter what medication we throw at you, no matter if we combine it or whatever, we cannot change the natural history of the disease. And the natural history of the disease is that it's going to progress and get so far down the road that nothing but surgery will help. You could throw 25 medications all at once. It's never going to work because the inflammation's gone. You need surgery. So surgery should be discussed with every single patient up front who has moderate to severe inflammation prior to starting biologics as a potential treatment modality. And I will send my patients absolutely to the surgeons. It just so happens that most patients are like, no, hold off. I don't want to see the surgeon. Yeah, please try a medication first. Let's try one of these biologics. I'll take my 40 to 60% chance. I'll be optimistic. It may work. I really trust you. I believe in a little bit of the placebo thing, you know, how you sold it to me driving the bus or the flying the plane analogy. I believe the power of the mind really works. I somehow do. I really think if the patient buys in that the treatment will work, I am optimistic that 40 to 60% is higher. In the clinical trials, like the data is not that encouraging, but in real life, I actually find that I don't want to, you know, I'm not trying to toot my own horn, but in real life, I find that it's higher than 40 to 60%. To put a bow on your question, which was the initial part, which is if your first biologic fails, the chances is your second biologic won't work as well, and third, and so on and so forth. That is true. That's what a lot of the data is showing. With some of our newer agents, what we're finding is that if a patient has failed a TNF agent, which is usually the one that we're studying, so if they failed the Remicade or the Humiras initially, some of the newer drugs show that you're still able to capture the same response. You're still sometimes able to get into that 40 to 60% range. So for example, ozanimod is a new medication that has just recently been approved. It's an oral medication for ulcerative colitis. We're seeing that even insulin failures, it might not be, you know, up to 60%, it isn't, but we are still seeing that despite failing, it's doing much, much better comparative, you know, in terms of the placebo effect. We're seeing a greater delta. So it's not all lost. It is definitely not all lost in that situation. Stelara had very good data for ulcerative colitis after failing a TNF agent. So again, it's not all completely lost that if you fail one, it won't work. The key point to say here, and why I underline this, because I find it so important, is we use this term, there's a key time period that if you intervene with the right treatment, you can affect the natural history and course of the disease. So for example, someone gets diagnosed with ulcerative colitis or Crohn's disease at a specific date. There's a certain time period in early on when you diagnose them that if you treat it in a certain way, you can affect the natural history of what's going to happen to the disease. So if you find the right treatment in the first 3 months, this is so important. This is why patients who get diagnosed with this should be seen urgently by an IBDologist, I would say, is because you can intervene, and maybe if you find the right treatment, they won't need surgery down the road. If you pick the right biologic to start, maybe you look at their extraintestinal manifestations and that helps you figure it out. Maybe it's something else. Maybe you're able to change what happens 10 years from now or 5 years from now or 2 years from now, or how they respond to future biologics. So that is also an important point. I'm emphasizing this because for us, this is so critical. And I really want to underline that point.
Is there a difference in the people that participate in clinical trials and the patients that you're treating every day that might be part of the reason why people in clinical trials are 40 to 60%, but the people that you're actually treating are actually at a different rate?
Yes, absolutely. I mean, for a variety of reasons. I mean, the first reason is that to enter a clinical trial, you need a specific scoring system to enroll. They often have very stringent criteria, what is defined as clinical response or clinical remission. And these are such specific scoring systems that need to be taken. I'll give you guys a small sub story that I'll tell you about my day today, which was really sad for me. I'm not going to violate any HIPAA regulations here, but it was my procedure day, so I was doing scopes today, and one of my colleagues had seen a younger patient who has Crohn's disease and has no insurance. Very sad story, has no insurance. And as a way to get around it, it was like, well, hey, let's enroll this patient into a clinical trial. We enroll them in a clinical trial. That way their colonoscopy gets covered. That way their medication gets covered. Their blood work gets covered. You kind of are able to still give them all the great care and perhaps give them the drug. So here I am about to scope this patient. My goodness, like, this is a little bit, sad to me today. So we're about to scope the patient. I spoke to him beforehand in the pre-op area. We wheel the patient into the room. We're about to start giving anesthesia. At this point, I see the study coordinator who comes in and says, we can't do the colonoscopy. And I'm like, what do you mean? The patient's on their left side. They drank their prep the night before. They're ready to get the scope. What do you mean we can't? Well, we can't do it. They don't qualify for the clinical trial. I'm like, what do you mean they don't qualify? They're like, he's too sick. I'm like, he's too sick. What? So, and why are we just finding this out now when the patient's about to get scoped, like literally in that position? Like, the poor patient drank all the prep, was ready for it. And in this case, there's a Crohn's disease activity index. And not to get too specific, but just to give kind of numbers into perspective, the scoring system to enter the trial, you need to be between 150 and 450. So that's the number. He happened to be over 600, like his score. So he can't enter the clinical trial because he's over the score. Now, you could be under the score, less than 150, and you would be, he's over the score. And it was so sad. And we were trying everything. The reason it happened last minute is everyone was trying desperately to call the drug companies, the investigators, the clinical trialists, like, please, can you make an exemption? This poor patient needs this scope. We need to help them. And we were trying to the very last minute to try to get that approved, and it wasn't, unfortunately. But the point is, when you enter these clinical trials, not only do you need a specific scoring system before you even enter and get enrolled, then to be part of this 40 or 60%, or in some cases, ozanimod's data was 18%. So it was much lower when you look at that. But compared to placebo was 6%. And so you see a difference and you're like, well, it works, but 18%, my goodness, that's great. 18 doesn't again sound inspiring, but it's better than placebo at 6. And what they need is endoscopic remission. So when you do the colonoscopy, you don't see inflammation. When you take the biopsies, you don't see inflammation. When you look at their symptoms are better from bowel movement, pain. So there's all these very, very, very stringent criteria to state that, hey, you are in remission, or you have responded, et cetera, or that you're able to be enrolled or not. Like, I don't want to use the expression hot mess, but it is a little bit of a hot mess express. Like, who the heck qualifies? And like, how do we get you in? And how do we get you defined as, yes, you got better? And so in real life, so there's the clinical trial data, and then there's the real life data. And you'll see some trials get published as real life experience as opposed to clinical trial experience. And real life experience would probably tell you that the number is closer to 60 than 40. And real life will probably tell you that in certain situations, if you intervene early enough, you'll affect the natural history and, might be higher than 60%. So I don't want to paint a negative picture. It's just the clinical trial data is much, much, much more difficult and stringent to qualify as that clinical response and clinical remission.
I think I've also heard that one of the struggles with clinical trials is that people have to be what they refer to as treatment naive, as in they haven't tried anything before, and that's how they end up getting enrolled. And so people like this guy, who unfortunately didn't qualify because of the one test, would be the ideal person because he hadn't ever tried anything. Is that right?
Well, usually that is the case, Lucia. So that's a good point. But in his case, which actually makes it even more sad, like what I'm about to tell you, you're gonna be like, you've got to be kidding me. So to enter this trial, you needed to be off of biologics for a certain period of time.
Okay.
And we took him off the biologic, which didn't seem to be working. And of course, he got worse while being off the biologic. So what happened? He got worse. His symptoms got worse. His blood tests got worse. His score got worse. And now he's not qualified for the study because everything got worse because you stopped the medication beforehand, and now he can't even be enrolled. So it was like, that was a very hard conversation with him, very hard conversation with parents. There were tears that were shed. Our study coordinator, who's wonderful, who's excellent, was tearing up too, felt so guilty and felt so sad about the situation. Our heart, and this is why you have folks like myself who are so passionate about Crohn's and ulcerative colitis. I saw my friend, to bring it back a little bit full circle, at my very early training onset, struggling and crying and losing weight and feeling sick and constantly in hospital, and all of us feeling helpless. What do we do? Needed surgery help, Band-Aid, need more surgery. It was gut-wrenching, and seeing it today again, gut-wrenching, so sad. I teared up multiple. I tried holding it in. It was hard for me. I'll admit it. I wanted to kind of go into a corner or into a room and cry for a little bit today because I saw the tears and patients, just bawling, and the parents were bawling, and everyone's desperate. And and we couldn't help them. And that's why you have, people like myself who are so passionate and dedicated to Crohn's and ulcerative colitis, that one day, hopefully we can find a cure. One day, hopefully we can find a gut specific agent, and 94 and 95% success rate, and God willing, 99 and 100% success rate. So that's the challenge. That's the hope. That's the ambition.
Ugh. Yeah, that's no pun intended, but that's a shitty day right there. And we were going to ask you about to compare and contrast the Canadian healthcare system and the United States healthcare system, but that's a whole heck of a conversation. And frankly, I don't think that's something that we can tackle today, because after you telling us that, I'm sure this hurts a little bit worse too, to know that this isn't the case in other places. And so it's an incredibly frustrating system. Incredibly frustrating.
Definitely, yeah.
Yeah. So we'll just have to bring you back to talk about
exactly.
To compare and contrast for us the differences between Canadian, because we've been talking to you for a while. I mean, we've been talking for over an hour. So
yes,
wow.
Yeah. So we're going to ask you one final question, and then I may ask you one too. Well, actually, here, I'm going to ask you this one. So you have a strange little side hustle of being like Ask the Doc on Canadian television. How the heck
do you?
Did this happen? Like, what?
You didn't tell me this, Alicia.
I did not, Robin. I threw this in as a little curiosity.
Yeah, I started doing TV, ironically, it was 5 years ago, like last week. I got this Facebook notification. I'm sure you guys get Facebook notifications about memories. And this memory came up that 5 years ago, I started doing TV. And I was a resident at that point. And I remember it like it was yesterday. I received this random Facebook message one day. At that time, over 5 years ago, it was like, hey, Lucas, I have this interesting proposition for you. Let me know if you want to talk about it any further. And I like read this vague message, and I was like, oh my God, what the heck does this mean? Like, what am I being asked to do? I wasn't really sure. And I didn't really, at first, I didn't even know who it was coming from. And so then I clicked on the profile, and I saw we had like 20, 30 mutual friends. And it was someone from my high school who was a producer for a national TV station in Canada. And I was in Canada at the time. It was kind of like the equivalent of a CBS or a Fox or an ABC in Canada. And I was like, oh my gosh. And I remember replying back, and I said, hey, it's been a long time. What's up? What's going on? What's happening? And the next message was, hey, we see that you're a medical expert, and we'd love to have you on as our doctor or medical expert on our news station. Would you be, do you want to meet? Do you want to talk about this? And I remember reading this message and being like, oh my gosh, this is so crazy. I mean, I was a young puppy, and I had no aspirations to go on TV or do any of those things. And I remember calling my best friend at the time in that moment, and I called him. I said, hey, do you believe they want me to go on TV? They want me to be one of these TV doctors. And I'm like, this is so like interesting or weird, or I don't even know. Like, I mean, I didn't have like these crazy positive emotions. And he turns to me, he's like, so that's so cool. You're going to do it. You're going to do it. You're going to do it. And I'm like, no, heck no, I'm not going to do this. I'm not going on TV. Why would I go on TV? I mean, like, I have no talent. I have no, I don't know what to do. I'm not a performance art person. Like, I don't know what I'm saying or what I'm going to do. He's like, what? Yeah, and plus I'll probably be terrible. Like, I don't know what I'm saying or how to say it, and I don't want to suck, and I'm scared to do it, to be honest with you. So I'm not going to do it. And he turned to me and he said something which has stuck to me to this day. But he said to me, in life, if God ever gives you an opportunity that scares you, you have to do it. And as he was saying it, I found myself nodding. I was like, what kind of human being would I be if I get this amazing opportunity and I'm too afraid to do it, so I don't do it? Like, I have to do it. Like, I have to try. If I stink, I stink, and it is what it is. I'll embarrass myself on national TV, but I at least have to try. Like, I don't know. Like, what am I going to tell my kids one day? Like, don't do something that scares you because you might suck at it. No, like, do your best. And if you stink, you stink, but do your best. Try your best. Stay optimistic. And so I contacted the producer who I knew from high school. I hadn't seen in, over 10 years at that point, and said, hey, let's meet for a drink. And we had a drink, and he said, look, I'd love for you to go on our TV. I'm like, don't I need to audition? He's like, no, from this conversation, I can tell you're going to be great. And so 2 weeks go by, and I get a call like the day before. They're like, hey, we'd love to have you in studio tomorrow. Come, we'll do a quick little segment. And I was like, okay. All right, let's do this. And I showed up, and it was one of the most terrifying experiences of my life. I mean, I had gigantic pit stains. I'll never forget. I was wearing this pink shirt. I mean, my armpits were soaked. I was so embarrassed. I was so nervous. And was live TV. It was unrehearsed. I had cameras going in and out of my face. I'm like, where do I look? What do I say? How do I didn't know what was happening. It was all such a blur, such an adrenaline rush. And I wasn't talking about just GI stuff. I wasn't talking about IBD. I mean, I was an internal medicine resident at the time, so I was proficient to be able to talk about everything. And since then, like, I don't know, like we did so many. I mean, I probably have over like 100 media appearances after that. Started doing Fox in Minneapolis as well when I moved to the States, and did a lot of radio and had been going on the Canadian show for a lot of time. In fact, talked about COVID for 6 months. I mean, I was doing 2-3 media sessions a week at the height of COVID when it first started. And I enjoy the media aspect. It's really, really cool to me. It's a lot of fun. It's a crazy adrenaline rush in that moment to be on live, unrehearsed national TV. Oh my gosh. Like, you know, you got to get it right. You got to get the information out. And here with you guys, I could talk for quite a bit of time, but on TV, you have 30 seconds. You have 30 seconds generally to answer a question and be concise and to the point and in such a way that everyone can understand you. But I really liked it. I probably a year ago, I took a break from it because COVID became too, it almost like was affecting my quality of life because I felt like I was under the microscope with everything I did. And so many people were questioning me about COVID. And it just got so overwhelming. I needed a little bit of a break away from it. But one day I'll get back into the TV for sure because I definitely do enjoy doing it. So yeah, so that's kind of the story.
I will be Googling this later, by the way.
Oh yeah.
No, don't watch. No,
yeah.
don't watch. Maybe,
we're
no,
watching.
No, it's embarrassing.
Oh, we are definitely watching.
We're going to link
Listen,
to it in the show notes. It's going to be
That's
so
right.
good.
Yes, I will
don't,
be putting
don't.
it on our Instagram account in the stories, like little clips of your. Yes, this is
I've
happening.
seen some of
Lucas,
them.
this is happening.
You did an excellent job, and you're very polished. Okay, the last question we always ask is, if you could give our patient community one piece of advice, what would it be?
Well, I think there's two pieces of advice. I mean, the first one that comes to mind is, number one, please, as probably you'll anticipate me saying, is please go get seen by an IBDologist or someone who specializes in IBD. That could go a long way in affecting your quality of life and your care and your management. It's not to take you away from your local gastroenterologist. Well, we're very happy to work with your community gastroenterologist. We're happy to give some information, a management plan, and then maintain that relationship. So that's part one. And briefly about part two, I mean, we didn't talk much about diet today, but diet seems to play an important role. And there's different parts of the diet that I often will tell my patients. So dairy, try to stay off of dairy, try to stay off of artificial sugars, processed foods, limit your red meat intake. If you're going to do red meat, please try to get natural, grass-fed, organic, open range. That seems to be better, but even try to limit that if possible. Stay with your lean meat, so your turkeys, your chickens, your fish. That seems to go a long way. But the dietary component is very, very important if you can. So again, artificial sugars, processed foods, those are your no-nos. Dairy, usually stay away from. Red meat limit. That's a good, starting point of slowing down some of the inflammation to your gut.
Yeah,
I will also add, work with an RD that specializes in IBD, please,
Yes.
because different people are going to have to limit different foods. So we don't want to cause
disordered eating.
Disordered eating, right?
Yeah.
So I don't want to take away from what you said, but I also don't want to encourage people to just start cutting stuff out of their diet without speaking to their GI or an RD that specializes in IBD.
Yeah.
No, excellent point. Excellent point. And I often work with a dietitian very closely who will always echo these statements. So by no means, again, when you get set up with a gastroenterologist, I have to get seen by a dietitian. They'll have many different positive little tips that you can incorporate into your own life. So absolutely, very critical. Dietitian, great piece of advice there, Robin.
Well, Dr. Kwapisz, because it's fun to say, thank you so very much for joining us. It was such a delight to have such a celebrity really in our presence. So we had so much fun talking to you. I hope you'll come back and we'll have a whole separate conversation about fixing the healthcare system. I think that's going to be a much longer than an hour-long episode. So we appreciate you coming.
Awesome.
Thank you so much.
Thanks for having me on, guys. I appreciate you guys. All right. Hi, everyone. It's Dr. Lukasz Kwapisz. I hope you enjoyed today's episode. If you enjoyed it, please like, subscribe, rate, and share with your friends. It would be great for you guys to all listen. And thank you so much for being a part of this with us today.